Good afternoon, everyone. I just want to remind you to put your audio on mute unless you're speaking and use the chat uh, section for any questions until the end. I'll be monitoring the chat throughout the session. So if we miss you, I'll catch back up to you and we'll address any questions you have here. So thank you again for attending. If you don't know, my name is Dwayne Spencer. I am the EMS for Children State Partnership Manager for Pennsylvania, and I want to welcome you to our learning session. Just a little bit of review. The Pennsylvania EMS for Children program is part of a HRSA initiative that is through the Maternal Child Safety Bureau. Pennsylvania is one of 50 states and 7 territories that have a state partnership program, and our effort is to support pediatric readiness through pre-hospital EMS agencies and emergency departments, and specifically with this effort to support the Pennsylvania Pediatric Emergency Care Coordinator effort that started in our state back in 2018 as part of a 7-state collaborative. Our program is, like I said, one of the state partnership programs, comes down through an award of a grant through the Pennsylvania Department of Health, Bureau of EMS, which is then subcontracted down to the Pennsylvania Emergency Health Services Council, where the EMS for Children program resides. And within the program, we have a advisory committee, and we also have a family advisory network. And a little blurb on that: we are expanding the family advisory network, and I'm looking for interested individuals who are either parents or caregivers of children with complex care, special care needs, or who work with agencies who support the care of children of that level, to kind of expand our program a little more than just a single individual. We already have some growth, and I'm continuing to seek interest in that. So if anyone knows of or isn't interested themselves, please reach out to me or have them reach out to me via email with any questions. Within the MSc program, we have some specific activities we handle. Our volunteer recognition program for pre-hospital agencies has been around since 2013. We're part of the Pennsylvania Pediatric Emergency Care Coordinator program right now. We also have a lot of effort on safe transport in ambulances, and we are developing a hospital readiness and recognition program. More to come on that in the next few months as we continue to roll that out. So you who are invited here are PECC champions. You're engaged with pediatric care as coordinators. We want to share resources with neighboring agencies and hospitals as PECC, so we don't repeat things we do. Redundancy has a good effect, but repetitiveness and doubling workload and tripling workload doesn't have good outcome. So we want to support the growth with the PECC initiative and support the development of new PECC programs locally at your agency, regionally within your EMS region, or just in your communities and statewide. Any questions or thoughts or comments, you can email admin@papec.org. So today's agenda has 2 pieces of it. I'm going to give you a little bit of the feedback from the learning session in July with the information we had asked people to respond to, gauging a little bit about you and what you're getting from the sessions. And then our speakers today are going to present on pediatric skills and scenario education with optimal pediatric preparedness for EMS clinicians through simulation and other educational strategies. Reminder that EMS continuing education information for this program session will be available at the conclusion. So a little bit about feedback from July. The first question was, have you attended previous PECC sessions to date? And about 2/3 of the attendees had. So I was glad to see we have new attendees, and we'll get a mix throughout, recognizing that not everybody's available with each of the sessions, but we want to make sure that we try and continue to build attendance and get people access to this information. The next question about how likely do you expect to continue to attend sessions? A little bit more of those people felt they were very likely, but everyone was likely to attend. And I like to see that. I'm glad that you're finding these informational sessions value. your experience rating, your experience with the past learning sessions, good satisfactions there. Again, I'm glad to see that. We want to continue that trend, and if there is anything that we have a burp in our delivery, we want to know about it offline. Please let me know. But again, it's feedback from the attendees of these sessions is really what's going to drive them in the future. And then I kind of summarized what topics you'd like to see in future learning sessions. And these are the top ones as far as BLS pediatric skills, ways to find other training for providers for peds, not just the PECC itself, pediatric trauma, respiratory critical care, peds bags and peds dosing materials, pediatric equipment and supply options, assessment of medication administrations, and pediatric mental health. I appreciate all that feedback. I'm going to take them and work on developing programs for each of those and seeing what we can roll out as timely as possible, but not trying to overlap too much as we go into the future here. A little bit about when the sessions, as far as weekday, weekday morning, weekday afternoon, weekday night, and as the original survey I sent out to the PECs, there was a lot of variation, but the core of the group preferred the afternoon. We are working on, and in fact, recording this session as we did the previous session, so they'll be available for people to view later. And that way you can get the information from the session. It's just not going to be live and interactive. How likely would you attend an in-person session, considering would we want to have something in person? And there is a desire to have something in person versus virtual. And we're going to consider that again for the future in 2023 as to how we can best meet your needs within our budget. And as well as, making sure, we get the right information out to you. We've got a big state, people have to travel if they're going to do in person, or we've got to travel to get it into a more regional approach. So those are the considerations right now. And, we're weighing that out. And just a little bit about the level of Pennsylvania EMS certification. 2/3 of the attendees are paramedics, but I'm glad to see that we have a large group of EMTs here, because it's not just limited to your clinical education, but this is a coordinator level. We have a lot of BLS services and QRSs that benefit from the information we get here. So I appreciate everyone's effort here, regardless of your level of certification here. So this session, a little different for us. We have some attendee polls. In fact, I have the first one to run here. If you're on a mobile device, you might have to swipe to get to it. But the attendee polls, this first one is just asking a little bit about what is your primary role here today. So if you could select the best answer, and we'll give you a few seconds here to do so. And this is more of a test on, can we get the polls out here for our presenters more than anything else. All right, that's 75% participation, but that's going to get that one out there. And sharing the results, so you can see about 3/4 of the group are PECs, but we have a few medical directors and several service administrators and a couple clinicians here. The invite for this went out from the state with a little burp in it that it didn't, the state's notice didn't have the date and time for the session. But it did note when the session recording was going to be available tomorrow night at 7 p.m. via YouTube, and the link to that, so that people will be able to view it tomorrow evening, or you can review it again if you want. It'll be available at that link. The continuing education is going to expire as far as applying for that, but the session will be up there for you to go back and reference if you want to.
Dwayne,
Yes.
I apologize. I missed the poll things there that you put up. I'm sorry.
Oh, that's fine. Don't worry about it. It was more to gather information about who's here, but also to make sure we have a little bit of the technology straightened out here.
Okay. It's Phil Banks from the City of Allentown Paramedics.
Okay, Good to hear you, Phil. All right. So that's it from me. That's the last you're going to hear from me talking for the rest of the day until the very end. But what I do want to do is introduce our presentation on pediatric skills and scenario education. This has been a lot of questions and how do you do it, or do you do it in surveys that you may have filled out in the past for the pediatric readiness surveys that you get annually and you'll continue to get. I just got an email today that's going to go live January 4th. But we didn't have a whole lot of information other than our scenarios manual, the book that we have published out there, on additional resources of how you can do it and how you can fit it into your agency's resources and ability to deliver something. So with that, I reached out to several of our emergency medical services for children national physicians who are very involved in this particular topic and using their expertise to provide you with some options as to how you can develop and implement a program that will help your EMS clinicians be better prepared for pediatric care through simulation and through some other alternative educational strategies. So our two presenters today are Dr. Marc Auerbach and Dr. Marc Cicero. Dr. Auerbach is a little under weather, so Dr. Cicero will be doing the bulk of the presentation today. They're both from up in the New England area in Yale School of Medicine. They both have a significant background in simulation and in pediatrics. I've met and worked with them both over my time with the PECC development and now as the program manager. And I am very glad to have them here to be able to provide you guys with some support here. I'm going to go ahead and give the hosting over to Dr. Cicero. So give me a moment while I get to that. And Dr. Cicero, it's all yours.
Thank you very much, Dwayne. Thank you for the opportunity to meet with you all today. Thanks for taking the time on behalf of Dr. Auerbach and myself. It was great to work with you, Dwayne, during the PECC collaborative some years ago now. It's kind of funny how time gets ahead of us. And as you said, we'll be talking today about means for improving preparedness for pediatric emergencies in the pre-hospital setting, largely through the lens of simulation debriefing, and some of the best things, perhaps, or our vision for this, some of the best things that you'll be taking from today's presentation are some ready-to-use, off-the-shelf, hopefully well-developed and no-cost resources that can be used to improve readiness for pre-hospital clinicians for pediatric emergencies. As we work our way through, one point of just technical piece, I wonder if in order to control the slides and advance them, if I should share my own slides to move through. Dwayne, would that be best? Or should I be able to do that with the interface the way it is?
Yeah, you won't have the polls in, that's the only thing.
Okay, maybe if it's okay, if this isn't too much, maybe I'll ask you to just advance the slides as we go so we can keep the polls. Is that okay?
Sure, can do that.
Great, let's move on from these two guys. We can move on to the next slide. Great. We'd like to acknowledge that we have received funding both from the National EIIC, or EMS Innovation and Improvement Center, and that the content here is collaborative, but doesn't necessarily represent the views of the government as it says there. And with that aside, we can move forward and take a look at some of the content that we'll be looking at today. Now, please take a look at this question as far as what a PECC does. For each agency, just like if you've seen one EMS agency, you've seen one EMS agency. If you've seen one PECC, we've seen what one PECC does within an agency. So the question that we have for you all to consider is, does your EMS agency have a designated pediatric emergency care coordinator? We'll use the word PECC and pediatric champion interchangeably. And if yes, which of the following roles does that PECC have within the agency? And set me straight if this isn't the case, but I think this actually is one of our poll questions. And here it is. You can just take a moment. This will give us an idea of PECC representation, and then also what roles PECCs do. And I think you can choose as many of these as you like, and as is appropriate for your agency. And we see really the breadth of everything it is that PECCs do for their agencies, ranging from advocating for children to looking at continuing education, to having a liaison relationship with receiving facilities, emergency departments, and the like, working with family representatives for family-centered care, and all of the many roles that you, as PECCs, as champions for pediatrics, have within your agencies. Curious to see which of these roles are most common among the PECCs represented on today's call, and if there are some that don't happen so often. Dwayne, I'll leave it to your discretion if we have a critical mass of respondents.
There you go.
Great. So not surprisingly, based on that first poll, we see that PECCs are well represented among the agencies in this group. And if we take a look at these poll results that I think will be popping up for everyone's Zooms, some of the most common pieces are promoting pediatric continuing education with 91%. We can see that some of the other more common roles include pediatric practice guidelines and being sure that they're followed. And a piece of that can be the quality piece and understanding pediatric practice as done versus ideal practice, and helping clinicians bridge any gaps. Another, perhaps among the three most common roles we see, is agency participation in pediatric prevention programs. And that can be anything from bike rodeos to car seat safety and other prevention means. Less common, and I think that this is true both in the hospital and in the pre-hospital setting, are the bridge between the EMS agency and the receiving facilities, the emphasis on family-centered care, and also pediatric research efforts. And I'm going to be the first to say that a person, in order to be an effective PECC, if a person puts their heart and their energy into a few of these efforts, they can make a real difference in their community. The message here isn't that a PECC needs to do all 9 of these things in order to be successful, but they do represent all the breadth of things that a PECC can do. And some of our work that's ongoing, that's part of a targeted issues grant here in Connecticut, as well as in Rhode Island and Colorado, is looking at the roles that PECCs play for their agencies and their communities, and how those various roles impact the quality of care that children receive and their ultimate outcomes. Any thoughts about that when you consider your own work as a PECC in your agency? And I'll say this too, as you consider that question, reflecting on your own PECC work, that it is actually a relief to see that we have nearly 36 participants who are here. And yet with this number of people, this is a small enough group that we can certainly have a conversation. So if you have questions or comments that you'd like to put in the chat, or if you'd like to speak up, definitely welcome that. As we like to say, no one has had to hear Marc Auerbach and Marc Cicero present on pediatric emergency care coordinators more than Marc and Marc. So it always makes for a better conversation when you as the audience participate. We can move on to the next slide, but certainly welcome your thoughts about any of those roles as PECCs. Our next poll question, as we roll up our sleeves and think about the roles of PECs and communities and think about the education piece, is, does your agency have a process that requires providers to demonstrate the correct use of pediatric specific equipment? And if it does, how often does it happen? So we can present this next poll question.
And it's 4 parts just because of the way to do the poll. So the first question, and then how often of each of the 3 types, if you would scroll down.
In the chat, Marc Auerbach has emphasized that this is a performance measure at the state level that is to be fulfilled by 2024, the demonstration of these skills.
And I'll also add, I don't recall exactly our state number, but I do recall that it's a steady up climb of a rate of increase. We're not at the performance measure goal, but we're headed in the right direction, in the 36 to 40%, I believe. So we're about the same participation here. So I'm going to end the poll. Give people about 5 more seconds. And there is your results.
The numbers as far as agencies that have such a requirement are almost the same as the number of agencies who have PECs. And this may not be a coincidence. That PECs are responsible for continuing education. It's one of the main missions. As far as how often it happens, for agencies that have it, it looks like it's at least on an annual basis, with nearly 1 in 5 agencies having it demonstrated 2 or more times a year. Some agencies have the demonstration less frequently. And as far as how often they're required to demonstrate their skills via simulation event, it's also pretty similar to the answer above. In other words, it looks like skill stations and simulations occur with similar frequency. As far as having a field encounter, however, those encounters are more difficult to capture. And we'll talk about that. Please keep that in mind. It's one of the great things about simulation is we can control to a great extent how often simulations happen. What we can't control is how often an EMS clinician sees a patient with, let's say, respiratory distress and asthma, or a patient who is in pain because of an orthopedic issue. So as far as having a demonstration via field encounter, more difficult to reach. And this is one of the real strengths of simulation, is a bridge to both establishing and maintaining competency. So thank you for participating in that poll. That piece, especially around question number 4, is pretty interesting as far as equipment goes. So we can move forward and think about a couple other questions. This one in particular, you're going to see these questions again in the end. And we'll be curious to see whether your responses to these questions are pretty much the same at the end of nearly 2 hours together, or whether there'll be some differences. So the questions that you're about to respond to, or that you can think about, include: what resources do you use for pediatric education? What do you currently use? What's the tradition or the standard in your agency? And what resources do you actually want or need for pediatric education? It's possible that for some agencies out there, what's currently being used is exactly what is wanted and needed, and that there's an ideal set of simulations or other resources that exist. It's also possible that for some agencies that there's a need for something more or something other than what's currently used.
So with this, we'll have to use the chat feature if you just want to enter in any particular information about the resources you use or want or need, so that we can have tracking on that.
Yeah, we'll definitely invite you to, to include that in the chat. It'd be very helpful to know what resources you're currently using for pediatric education, and and what Pennsylvania EMSC, what the national EIIC, or your friends from 2 states away here in Connecticut, what we may be able to provide to improve your pediatric education. So again, encouraging you to put those responses in the chat, or feel free to come off mute and share your thoughts. And in the meantime, we can move forward. I'll keep an eye on the chat, and happy to be interrupted if there are any off-the-cuff suggestions for things that are missing from the repertoire, ways to improve pediatric education. Okay, so our next question is, does your EMS agency have a collaboration with community hospitals on pediatric education? And if so, how is that done? And then next, does your agency interact with children's hospitals? And if yes, how? I see that some of the participants are from places like Pittsburgh and from Philadelphia. Others might be from Allentown or Harrisburg, or places that don't have a children's hospital per se. So the interactions with children's hospitals may be very local or regional. I'm curious about these pieces, and whether there have been attempts in the past to work with hospitals, and how that went.
And feel free to come off mute for these questions, because I think they'll provide feedback to everyone here as far as your interaction and what benefit you've had or what challenges you may have had. So in the chat, Andy Kieran says we have to currently borough members' children to simulate scenarios, and he would love to be able to have proper simulation equipment. The budget of a volunteer company is not there. A regional sim lab would be great to be able to be built.
Andy, thank you for sharing that. And man, I cannot wait to talk about SimBox as a means for overcoming some of those cost constraints that are associated with doing simulation. There are some really exciting low or no cost resources that we're going to talk about during this presentation. Marc Auerbach is echoing some of that. I see Kevin Trichtinger's from Community South EMS. I see your comment with little or no interaction with community hospitals. We do have education sessions with staff from University of Pittsburgh Children's. I think that your experience, Kevin, is at this point a pretty common one. I even see that here with our own EMS agencies and in our hospital, and we're working to build those bridges. We find that when we do education together and think about the continuum of care from EMS through the emergency department and then up into the hospital, and we do simulations and education together, we have a better understanding of what all we do. It fosters more respect for all that EMS does and can do for the betterment of children's health. And then Andy, I see your comment regarding the local ED not having a PECC. So meeting with the new medical director there. And and this is a chance, advocacy kind of flows both ways, in that the hospital-based PECC can certainly advocate for having a pediatric champion in EMS, and an EMS champion can do the same. And this way it helps build the liaison. It builds a role that someone who's already in a leadership role within the emergency department, or a person whose role is both as a clinician or a nurse and as a PECC, can then interface with the MS. And then if we have co-facilitation of education, and then meeting with folks who do training, so that EMS and the receiving hospital can work together for education. Marianne Higby, I see what you're saying regarding COVID, and getting closer to what things were like before the pandemic, and then also the relationship with CHOP. I have a friend who works in neonatology at CHOP, and this experience as far as a second hospital in the suburbs and more outreach to the communities as CHOP becomes even more accessible without having to delve into the city and any traffic or transportation related issues. I'll pause there. I think someone spoke up a moment ago.
Mark, this was me. Sorry, my voice is still a little bit off, but I would just encourage the group, if you are interested in pediatric simulation, I put our emails in the top. Please drop us a line. We have ways that we'll discuss today for virtual facilitation, but we also have lots of colleagues in Pennsylvania that are very eager to engage with pre-hospital providers. So some of this is matchmaking. There's a lot of people that want to teach, but don't necessarily have connections with the right audience. And then I think there's a lot of learners and facilitators. So please go ahead and drop us an email. And again, you'll hear today a little bit about this potential for Connecticut providers or Massachusetts providers to be facilitating in Pennsylvania. We've started some of this in Alaska, and we're really excited to share that.
Thanks for that, Mark. I'll also acknowledge your comment, Amanda Mutterspaw, regarding train.org and PA Train, and then there being a few sim options regarding pediatrics, but it's limited. I'll even go ahead and kind of plant this seed and say, I wonder, what the process is to get simulation resources and scenarios into train.org or PA Train. And I wonder whether it might be possible to include some of the resources that we'll talk about today to make them more accessible. And thank you very much to everybody's taking the time to comment. Don Urban from Kiel Hose Fire. We have some interactions with Children's Hospital of Pittsburgh, but wonder about reaching out to other cities that have children's hospitals to input as we're closer to Buffalo or Cleveland. In talking about Northwest PA, I think about places like Erie and, coming right down the 90 corridor toward Buffalo, where Dr. Auerbach and I trained a couple decades ago. It's going to be a heck of a season for the Bills. I don't know if that's okay to say right now, but anyway, yeah, absolutely. Interactions with all of your potential resources. There's, I think that you'll find that children's hospitals and community hospitals who care for children, more and more are looking for means for establishing connections with community hospitals and with EMS agencies who may be transporting or who are looking for educational resources. There's an understanding that 85 to 90% of children who are seen in a hospital or in an emergency department are seen in a general emergency department, and that EMS care is often delivered by community, volunteer, third service agencies, and that if we're going to improve the care of children in day-to-day emergencies as well as in disasters, that we need to be resources, for EMS agencies who are looking for that level of support. Other thoughts about that?
I'll just add one thing. There is a very strong network that originates out of the pediatric hospitals throughout the state into their existing referral facilities and training that goes from the children's hospital out to those referring facilities. And a lot of that training does include simulation, and getting tied in with your community hospital. Even if there's no PECC there yet, there's probably someone that facilitates or works with that. Our goal with hospital recognition is to first identify if they have a PECC, and if not, to get one on board, because just with EMS, that's going to be the key person to make recognition happen at the hospital level. So while we're working on hospital recognition, you can certainly be working on primary contacts within the hospital ED for engagement with pediatric care. If it's not there yet, keep those contacts active so that as we start to develop the recognition program, we may be reaching out to you for some of those contacts and engagement, because it is a collaborative of all the parties, not just, hospital versus EMS, but it's going to become a group effort here. It starts pre-hospital, it continues in the ED, and it finishes off when the child's discharged, wherever they're getting discharged from.
One more comment from the chat, and maybe we'll move on to some of our objectives and resources, is what you've brought up in the chat, Phil Banks, regarding battles with, if there's two patients who have been involved in an MVC and they're trauma patients, there's a parent, there's a child, as far as transport to a pediatric emergency care unit or trauma center and an adult, and if we're separating children, first, geographically set me straight. When we talk about the Lehigh Valley Emergency Department, my Pennsylvania geography could be better. Are we talking about Geisinger? Is that the Children's Emergency Department in Lehigh Valley?
Now it's
No,
out.
it's at Lehigh Valley, Cedar Crest.
Lehigh Valley, Cedar Crest. Thank you. It's the real dilemma as far as getting the parent and the child to the place where they're going to receive the best care, but also the anxiety that a parent and child might have about being separated. And how much distance is there between the children's emergency department and the adult emergency department? Are they on the same campus? Are they cross town, or are they at some?
No, they're on the same campus, but they're probably maybe like they're not on opposite sides. They're within close proximity, but they're not directly connected. Like all the trauma bays are in between the adult ER and the children's ER. So like if you're familiar with Lehigh Valley, the old ER is now the pediatric ER, and then the ER is now built out off towards where the helipad used to be. So what they've done is they've incorporated like a video so that the parent can watch the video on a closed caption TV within their room. But I know we've transported a couple patients there that parents like literally just want to get off the litter, and it kind of turns into a hard thing for us because we're trying to be understanding, but it gets frustrating because a parent wants to get off the litter and not be seen because they want to be with their child. So it makes it's kind of a frustration on that side of it.
I wish I had some insight or solution for this one. It's pretty difficult. Even our children's hospital is essentially a hospital within a hospital. We have a tower that's part of a larger general hospital, and we have a separate pediatric and adult emergency department that share a wall. They're adjacent to each other. And even then, when the child is 100 feet away, there can still be some reluctance on the part of parents. If others on the call have strategies that they use to reassure parents or means to improve that situation, I'd benefit from hearing them. But I hear you loud and clear, that can be an issue. And if we're talking about across town, or if the trauma center for children is part of a different campus, or if there are issues with parental refusal or communication barriers, all the more problem.
It's honestly a low percentage of the time that happens, because usually at like an MVA, there's one parent that's not injured, so we can always take that parent with the child. But maybe about 10% of the time we've had a situation where there's been a parent and a child transported together, and the peds ER doesn't want to have anything with the parent being in the same room as the child. They have to go to the adult ER, and it just gets to be a little frustrating sometimes.
Right, particularly for EMS. And in those situations, are there times when both the child and the parent are being transported in the same ambulance, or usually two ambulances being used?
We usually, if we can, we try to transport both together, but there's been situations where they've both required litters, so we had to take them both. But when you wheel the adult in, they're like, oh, you got to go to the adult ER. And, the parents just get a little, today's society, everybody wants to be with their child. And I get that. So it gets a little Yeah, it takes a little while to calm them down. So, I mean, it works out, but I can see where the frustration is on the parent side. And, I've reached out to a couple people, but, they're always revolving. So it's hard to really get a true answer. So I have the EMS liaison working on some of that for us.
Right. You bring up another important point is sometimes the person who was the pediatric champion in past years, those folks tend to migrate. Maybe they get promoted, maybe they go to a different system. Policies might change, throw in a pandemic, and visitation policies and these kinds of things, it becomes even more difficult. If nothing else, then this underscores that having a liaison with the receiving facilities can be a way to preemptively work out a solution to these, or it may not be enough. All right. I think we can move forward to our next slide, but please do keep those collaborative questions in mind. The objectives for the main part of this talk are to go in depth about simulation. What is a simulation? What's a simulator? And when we talk about high fidelity simulation, what are the bells and whistles that go with it? And how do they contribute to better education? Or even, to be provocative, do they actually contribute to better education? We'll look at 5 different elements of effective simulation. And I'm going to show you the cards a little bit and say that only one of those elements is the actual simulation itself. Then we'll take a look at details for pediatric simulation scenarios, sessions, and components. If you are taking a simulation off the shelf, perhaps you're taking one of the SimBox simulations and you're using it in your agency, or if you're designing your own simulation, what are the components? What are the pieces that we use to put one together? And then number 4, which possibly is the most valuable piece of participating today at all, is the free open access pediatric EMS skills and scenario resources that you can use in your agency. These are a set of simulations that are off the shelf, ready to go for singleton emergencies and also for disaster readiness. So those are our objectives. I'll continue to keep an eye on the chat, but also if anything I say doesn't really ring true for your experience in your agency, or it does, and you have something that you'd like to add, please share that with the group. We can move on to the next slide, please. Okay, so we'll take a look at some backgrounds and definitions as we think about simulation. We'll take a look at what makes a pediatric simulation effective, and then ways to implement these tools in your agency. And we can move on. First, we'll start with the backgrounds and definitions. We'll return to this slide a number of times, but this is the outline, and we'll return to the spine of this to let us know where we are in time and space. So backgrounds and definitions, we move on to the next slide and see that if we move past this one, we'll take a look at what is a simulation. A lot of times we talk about simulation, we think about some high fidelity, high stakes situation where there's a child who has a dysrhythmia, respiratory distress, and also a trauma who's coming in, and a whole multidisciplinary need team is coming into play. And that could be what we're doing. But a simulation is a technique for education or for testing readiness or for helping to understand how things are working. It's a technique, and it's not necessarily a costly technology or piece of equipment. We can do a simulator, or we can do a simulation with our imaginations, a video, and a pen that portrays the patient. So it's a technique for education and for testing systems. And as we look further, we can move on from the technique piece to think about that it amplifies or replaces real experiences. In that poll that you as a team responded to, you helped us understand that as far as having real world sign off on skills for pediatrics, that that doesn't happen so often. And simulation can be a way to bridge the gap. It's immersive, it's interactive, just like real patient care is. And it's the sort of thing that people become invested in, work together as a team. Their heart rates may go up, their thought processes go into play, their use of resources and the like. It's interactive, it's a team sport. And moving forward from how it replaces and amplifies, let's talk about the simulator. We just talked about the simulation. This is the simulator. A simulator can look like this sim baby that you see in the corner of the screen. It's an object or system designed to represent something real by imitation. So we could have a simulated care environment like what we see here. And fidelity is the degree to which our simulation or our simulator depicts the actual experience. A high fidelity simulator, for example, will depict physiology, might move, might cry, might have a seizure. And fidelity can also include all of the senses, including sounds and smells, in addition to what we see happening. When we choose a level of fidelity regarding the location for the simulation, it can happen in a clinical space. The highest fidelity in situ simulation might be for an EMS agency. It might be the back of a rig. It could be in a center. Earlier, one of the members of our group here had talked with us about developing a simulation center, perhaps an EMS simulation center, a shared set of resources that depicts a care environment, but is close to, but not exactly, the back of the rig or the clinical space. And another way to do it is we're not going to, but we could do a simulation right here with all of us, with the 28 of us who are on this call. We can do it by a telesimulation or home simulation. And there had already been some inroads for this prior to the pandemic, but it has really taken off as a means of education as a result of the pandemic. So all of these different levels of fidelity, as far as where it's happening, the fidelity of the mannequin, the fidelity and the realism of the equipment and medications, these are all part of fidelity. And it's not that there is a range of goodness based on the higher the fidelity, the better the simulation. It's more about what are the gives, and does the fidelity of our simulator and our simulation environment help us achieve those goals? Next slide, please. Why use simulation? We've talked about what is a simulation, what are simulators, why do it at all? We do it because it gets people invested. It's immersive. People are immersed in the task, and their setting is as close to the real world as it can be. It can be a way for teams to work together. It can be a way to test knowledge and skills. And we ask our team members who are participating to immerse themselves and make it real. There's a suspension of disbelief. The goal is to think through what needs to be done for that patient, how we're going to work as a team, and to do the actions that need to be done. I encourage you as PECs, as pediatric champions, and as you've told us, a big part of your role is education, is that if somebody says, okay, I go ahead and check the vital signs, say, well, please go ahead and check the vital signs on this simulated patient. Likewise, if they say, okay, I put in nasopharyngeal airway, say, well, please go ahead and do that. The goal is to do and to talk through what would be done. And then it's been said that the reason we do simulation, that the real learning happens afterward in the debriefing. A debriefing, we assign a really positive feel to a debriefing, because a debriefing is a chance to reflect on what happened, to understand gaps between the care that was demonstrated in the simulation and ideal care, and make a plan for improvement and to reflect on that experience. So that's why we do simulation. And again, in addition to being a great way to test and do education, it's also a way to test systems and see how best to improve systems. We can move forward, please. Okay, so we've talked about simulators, simulation, why we do simulation. Let's talk about the EMS environment. Earlier, we talked about how there aren't too many structured experiences clinically that involve children. We know that 10% of EMS patients are children, and 10% of that 10% are children who need to have some sort of intervention, or we might define as sick. They might have a problem with their pediatric assessment triangle. Feedback, getting some sort of evaluation of the care is rare, and there's potential for harm. So we can't just do clinical care and reach our best as far as the care. So what simulation lets us do, moving forward with the slides, is it augments and supplements what's happening clinically. We can do as many simulations as we have time and resources for. We can do many of them in a structured, controlled way so that EMS clinicians feel competent, and they objectively are competent because we have an established evaluation tool or set of benchmarks that we want them to be able to demonstrate. Feedback can be frequent. It can go beyond feedback. We'll take a look at some diagrams of feedback in a little bit, but it can go two ways. EMS clinicians can say to us, listen, let me give you the feedback that I don't have the right sized equipment, or, the receiving facility often criticizes us if we make this action. And then simulation is a low stakes environment. We can make as many errors as we want with simulated patients. And by making those errors, we can ensure that it's less likely we'll do errors for real patients. So that's why we do simulation for pediatric EMS. We can move forward, please. All right. So let's take a look at a historical gallery of simulators. What we see here, and Marc, you may want to give some history in the chat if you like, but this is a simulator made of leather that, as you've already gleaned, is a birth simulator. And this thing looks like it dates back to the days of leather helmets and football. But this is an early simulator used for demonstrating birth for learners. Moving forward, we can look at other earlier simulators and mannequins that might have been used to depict patients, or perhaps the use of cadavers for learning. And moving forward to a more recent form of simulation, here we can see the use of an early simulator for anesthesia, with an understanding that, just like from the aviation industry, that simulation allows us to take the patient up to a state of being anesthetized and safely go through a case and then safely landing them. The most dangerous times on a plane are takeoff and landing. The most dangerous times during a surgery are often induction and recovery from anesthesia. So in the OR, healthcare simulation got its start. But as we move forward, next slide, please, we can start to think about how simulation gets applied to a much more common setting, which is PALS training. What we see here is telesimulation with a depiction of the patient on the cot there, with two clinicians who are caring for the patient, and an opportunity to do remote simulation. Marc Auerbach has fleshed out some of the ideas here, including that medical simulation has been used for thousands of years, and that stone carvings from 20,000 years ago or 22,000 years ago depicted some simulation. The first documented practice, the use of simulators, dates back 1,700 years ago. That
Was that
OB
leather
mannequin that we
simulator?
saw.
Yeah.
Go ahead, Marc. I'll turn it
That was
over to
that
you.
leather mannequin was from 300 AD. And then I did want to highlight that the first pediatric mannequin is very similar to what we're using now, Resusci Ann, and that was developed by a toy manufacturer, Asmund Lardal, after, unfortunately, they had a child die due to drowning in Norway. And the Sim 1 mannequin, that last picture I just wanted to highlight, in $1968 cost over $1 million. So now that would be quite a bit more than that. The high technology, high-end mannequin really became sort of the in vogue thing. And hopefully by the end of the talk today, we can convince you that we can save you close to $1 million, hopefully.
Right. The best technology may not be the best fit for learners and their needs, regardless of who they are in healthcare. And again, the use of telesimulation through the Pediatric Advanced Life Support course that paramedics and others on this call will be familiar with. We can move forward to the next slide and take a look at the first freely available resource that we are going to share with you today. You can see the website disastertriagegame.org. This is a pediatric mass casualty video game and simulator that allows learners to practice their use of disaster triage and think about rapid interventions that are appropriate or inappropriate in settings like a tornado, a multiple family house fire, or a school shooting. Feel free to take a look at this. To date, 35,000 users have participated in this game, and it could be a good fit for both initial learning and just-in-time training before doing disaster triage. And it costs nothing to use. We can move on to the next slide. This is work done by a colleague of ours in Southern California, and Todd Chang and his group have been using virtual reality. Looking at the patient who's on the screen there on the cot, would anyone like to hazard a guess what sort of pediatric emergency this patient might be experiencing? Take a look at the skin, take a look at the pulse ox, which is the blue number you'll see on the right-hand side of the screen. Thank you very much. Yep. And Philip Banks had the answer prior to your prompt there, Marc Auerbach. Absolutely. So one example is a virtual reality immersive sort of training that can be done that also achieves a lot of the goals that we try to achieve in simulation regarding practice, communication, and doing. We can move on to the next slide, please. Other virtual reality applications can include the planning for complex surgeries, the pre-mapping of vascular networks, plans for the modeling of surgical approaches for neurosurgery, or practicing airway manipulations for young premature infants, so that a person develops a level of competency before they approach a real patient where the stakes are high. And we can move forward. And Dwayne in the chat is pointing out the sharing with Maine EMSC with virtual training. And also
Marc,
another way.
I'll comment on this one. So the most high fidelity simulators we have are our friends and colleagues. Sometimes those are our children. So this is just an example of likely the most realistic simulator that we can use, which is each other, but it becomes more challenging with our children. That's a whole other talk about enrolling other people's children, but Marc and I have both leveraged our children within simulations. And I would say that, just balancing the fact that you need to do some pre-briefing with them, hopefully protecting them from any psychological harm. But I think it's been a positive experience for our children as well as the providers.
Absolutely. And, if children are involved in simulations, often, if they're starting to get antsy with the amount of time that they've been portraying a patient, it might be a good prompt for us as facilitators, to look to move on to the next part of the educational experience, which will be the debriefing. So what we see here is the handoff. This is a crucial moment right now where there's a critically ill infant who's been brought by EMS and managed by EMS, brought to the receiving facility, and the handoff that occurs. This piece, simulating this piece with colleagues who are the PECC champions for your receiving hospitals, is an ideal. If we can get to the point where our EMS agencies are communicating with, and there's bidirectional flow of information and education, then we are achieving high levels of care for our patients. And we can also ensure that the protocol is the protocol for everything from asthma to croup to other common pediatric issues. It is seamlessly integrated from the pre-hospital setting to the receiving facility. And we can move forward, please. All right. So the next couple of slides are some information about a review that happened. It was in Journal of American Medical Association a little over a decade ago now. This was a systematic review and a meta-analysis, essentially pooling data from other studies to take a look at how simulation that was enhanced by technology improved health professions education. And if we just kind of move this forward, we can look at some of the main findings. That when technology enhanced simulation was used, it was associated with big effects for provider outcomes in knowledge, skills, and behaviors, and some smaller but real effects for patient outcomes. And keep that in mind, because at the very tippy top, the holy grail of what we're trying to do with healthcare education is improve patient outcomes. And the fact that this study, which pooled data from other studies 11 years ago, showed some improvements is really heartening, and another strong endorsement for using simulation in our education. We can move forward, please.
All right, let me know if there's no audio as we move to the next slide.
So that clip, not only does it conclude the first part of our talk regarding backgrounds and definitions, example of so many things that can be improved with simulation, ranging from matching goals and objectives to the simulator, to having a common understanding of what's going to be done with the simulation. Perhaps there are those on the call who've served as a facilitator for a simulation and have experienced a level of frustration that mirrors that of the Red Cross facilitator that we saw in that CPR course. And also willingness for learners, them being ready to learn. There's some good intentions there, but as far as communication among the facilitator, among Michael Scott from the office in Scranton, and also the willingness of learners to participate, what went well there? I'm right there with you, Andy. Really not too much, other than there was an opportunity to learn. But as far as matching goals and objectives, as far as feedback, and as far as undermining the learning piece. So that's why during this section, we're going to talk about effective pediatric EMS simulation and means for establishing an effective, safe place for people to learn. Marc Auerbach brings up the idea that simulation can be fun, and it looks like there are some folks definitely having fun there. And the rest of the video with organ retrieval is also worth a look after. But that is a classic example of how if we don't set up effective pediatric EMS simulation, or just simulation in general, things can go off the rails. So we can move forward, and we'll talk about setting the stage for effective pediatric EMS simulation as far as setting the ground rules, setting a common mission. Earlier, we talked about how we can practice as many simulations as we want. If we think about deliberate practice and having a checklist or a set of outcomes that we want for our learners to be able to do, maybe it's something as simple as patting the shoulders of a child because of their big occiput when we're getting ready to do bag valve mask ventilation, and then effectively choosing the right mask, maybe placing an NP airway or OP airway. Let's think about practice in a way like Vince Lombardi, that practice doesn't make perfect, only perfect practice makes perfect. There's a real truism in healthcare and in EMS that we perform the way we practice. And by ensuring that at the end of an educational intervention that people are doing things perfectly, we still aren't sure that weeks or months later that they'll still be able to do it. But one thing that's certain is if there are still persistent errors after a simulation session, that providers aren't so likely to be able to do what they need to do when there's a real patient who needs them. We can move forward, please. All right. Now, earlier, there was an allusion to the fact there's 5 elements to effective simulation, and here they are. First is setting the stage. We'll talk about pre-briefing, feedback, and debriefing. Setting the stage, and then what's the difference between a feedback and a debriefing. And then repetitive practice, the Vince Lombardi. Perfect practice leads to perfect performance. We'll take a look at clinical variation with a range of difficulty. Initially, if somebody's going from not so competent to competent, we want for them to be able to establish all of the pieces of their actions that we want them to demonstrate. But then as they move toward expertise, we want to have a range of difficulty and have some variations and some ways to do some on-the-spot troubleshooting. We want to have valid simulators. Notice that it doesn't say high fidelity or costly simulators, but we want to have a simulator that helps us achieve our goal and that we can all agree that the patient simulator in front of us is the patient and we can do the skills we need to and do the learning that we need to with that simulator. And also we need to have defined outcomes. When we go back to that scene at Dunder Mifflin and Scranton, as far as defined outcomes, I think there are some very different kind of mental models of what the defined outcomes were. I think that Michael Scott wanted to be sure that his coworker Stanley could be resuscitated in case his heart went on the fritz again. But the Red Cross instructor wanted to ensure that everyone knew how to do high quality CPR, and having a same mental model as far as what the defined outcomes is an element for effective simulation. And we could please move forward. First, we'll talk about pre-briefing, debriefing, and feedback. So it's been said again that we do simulation in order to do debriefing. We want to be sure that we have a cycle here where we talk about engaging in the simulation scenario and that people have the concrete experience of working through the simulation as a team, as an individual, and applying skills and knowledge. Then reflecting on that experience, we begin to think about reflecting on the experience in the process of debriefing, observations made about the actions that were done during the simulation, gaps that might be revealed, and also an understanding of what people's thought process was regarding the care. Then, as we move from the observations about that concrete experience, we want to generalize it with abstract conceptualization, reflect on the experience, and then learn from the experience. In other words, after doing this simulation and this debriefing, what might I change about my practice? What will I do the next time I encounter a patient who has severe croup and respiratory distress? Future actions and experimentation and the trying out what has been learned, either with a new simulation or in a clinical setting. And what's great ethically about this Kolb's cycle that we've been walking through right now is that it allows us to practice and practice and practice with simulation, and also practice after there's been a clinical exposure to that not so common and sometimes anxiety provoking ill or injured child. We can move forward if you'd be so kind. So we walk our way from doing the simulation. We take a look at learning from the experience and trying out what we've learned. We can move forward, please. Learning and then applying it to a real clinical situation. As promised earlier, we said, and we can even click forward for comparison's sake. There's feedback, where the T here stands for the teacher and the L stands for learner. And this, from an educational standpoint, is what we might call pedagogical learning, where there's an imparting of knowledge from the teacher to the learner. Information is being presented to the learner, and there's a one-way flow of information. Let's compare that with debriefing if we move forward. Debriefing is a two-way bidirectional flow of information from the facilitator, not a teacher, but a facilitator. I find that as a facilitator, I'm often learning right alongside my EMS colleagues. I'm learning about changes in the protocols. I'm understanding limitations for what's available in the back of the ambulance as compared to in the emergency department. Bidirectional flow, there's a conversation and a reflection on the practice, and also an understanding that the learner here is an adult learner and that it's not just flow of information from the teacher to the learner, but a two-way flow of information. We can move forward, please. All right, so this is a way to do debriefing. There are so many different elements to debriefing, but as we flow from step 1 to step 5 here, this is a scaffold that you can use if you find yourself debriefing. And it's also a way to sort of demystify the process and give you a roadmap for doing it. So this healthcare debriefing tool, which is available at the QR code that you see there, which I encourage you to perhaps scan with your phone or make a note of, and this will be available on the recording as well, is a way to first set the scene, create a safe context, sort of thing we might want to say in our pre-briefing before the simulation, we might repeat here. We have an understanding that everybody here is a professional, people are intelligent and they want to do well, and that everybody's here to have a safe place. And you might say things like, let's spend a few minutes debriefing. Our goal is to improve how we work together, and everyone here is intelligent and wants to improve. So the next phase, once we've set the stage, is to let the learners share with us. A lot of these are very open-ended questions. How did that feel? In what ways was that simulation like your previous experiences caring for patients like this? What are your initial reactions? How do you feel? And then we go on to give a description of the situation. And the facilitator can take a really exploratory role with this, but not be the one who provides too much of the content. We can help have a shared understanding of the case. You ask the participants, please share a summary of what happened. What was the working diagnosis, or what was your differential? Does anyone have other thoughts? How do you feel that your diagnosis changed as you got new information? And describe the situation. Once we've described the situation and have an evaluation or an impression of the patient, we then do some analysis. We take a look at performance and consider, spending some time talking about the management of the patient. And perhaps we say, because I noticed that the patient wasn't breathing and didn't have a pulse, and CPR was started after about 5 minutes into the case. Please tell me more about that, for example. And then doing a summary again. That was a really good discussion. What other comments do you have regarding management of the airway, asking for help, interfacing with medical direction, beginning or obtaining vascular access and the like? And then, I always like to say that the first person who should speak in a debriefing is probably the facilitator, and the last person who should speak in a debriefing is almost certainly one of the participants. We want to identify takeaways. It's learner-centered. What are some of the things that you'll take away from this simulation experience? How might it change your practice? Versus instructor-centered issues or pieces that might be shared in the summary. If you're going to share these, I'd say share them before the learners share their thoughts. The key learning points here were that croup can progress and cause life-threatening airway situation if left untreated, for example. But all the better if the learners are the ones who share that information. So this is one debriefing tool, and debriefing is an important element of how we manage simulation. If we can move to the next slide, please. So one of those phases in the Pearls debriefing piece is the analysis. This is a way we look at the various performance pieces, everything from communication among the team to awareness of what's happening for the patient, for say worsening or improving vital signs, and also technical skills ranging from airway management to vascular access, and having 3 approaches. A favorite of ours is learner self-assessment, where the learner, who is a professional and an adult, is taking a look at their performance. You might ask them things like, what was managed well and why? And what might you change if you had the opportunity to, and why? You can also do the number 2 there, which is focused facilitation, where we probe deeper. This advocacy or advocacy inquiry piece is really a helpful piece to put in your back pocket. I noticed that the nasal pharyngeal airway that you used was a bit larger than maybe expected because it stuck out of the child's nose. I think that could have changed and maybe been optimized. How do you see it? What were your thoughts about that nasopharyngeal airway? Or you might just say, I know, go ahead, Marc.
Oh, sorry, I did not mean to do that so aggressively. I want to flag that this is a change for those of us that trained 20 years ago, where really we were giving feedback, and we were giving feedback in a way that perhaps was quite different than this. So I do want to flag that if you are, probably above 40, 45 years of age, that this is likely a shift. And perhaps in all of EMS, this is a big shift to go from, just stating this is what you did wrong, to exploring really that deepening of why they did that and why they made that decision. So I just wanted to put a flagpole on the ground just to sort of state that this is a change in practice for all of us and was a journey. It doesn't happen overnight, but I think it has really transformed my educational experiences with EMS.
Right. And if we approach it with that sort of open-mindedness, sometimes we find that it's not a knowledge gap or that the person in front of us doesn't know what they're doing. We may find that there is a pattern of practice within an EMS agency, or an absence of necessary equipment, or some practice variations that are based in the reality and the best practices for that agency. Another way to go about it is as far as providing information. Rather than putting on our professorial hat and sharing information, you might first ground it in what happened during the simulation. I noticed that you used a good C and E clamp with the mask for the patient, and still chest rise didn't happen so well. Next time, you might want to try padding the shoulders because of the big occiput that the child has, and that, in my experience, has improved oxygenation and ventilation for patients in this situation. So the providing information piece. And we can move through the analysis phase and on to our next slide, where we're going to consider the pre-briefing. So that last part, the analysis, is part of our debriefing after. Let's talk a little bit more about the pre-briefing, about setting the stage before the simulation even happens. We want to—
Marc, I'll just flag here and trying to keep my voice rested, but I would say this is the area that often when we're in a rush, we jump over. And I would say, looking at simulations, this is something that I will never look back and say like, oh, darn, I wasted all that time pre-briefing. I really think that to set up the optimal experience for your learners, this is absolutely critical. And you'll see with our SimBox work, we really try to get this down to 90 to 120 seconds. But I would argue that even for a 10-minute simulation experience, this is a critical element that I think if you skip over, it may become the office simulation that we viewed, where the learners aren't engaged, they don't understand what they're showing up for.
Thanks for that. And basically, this can be something as simple as, this is a safe place to learn. Your supervisors and your colleagues won't know about how this goes. This is a place where we can learn together, where it's okay to make mistakes, and the simulator is not going to be harmed by what we do. And this way we can do a better job with children in the future. We understand that there are limitations to simulation. This is not reality, but we're trying to approximate reality. And this is for education. This isn't about assessing you. And also that the results here are confidential. We can move forward. Our basic assumption, again, is that everyone is looking to learn and to do a better job, and that they're intelligent and capable. And we're coming together as a set of equals. We can move forward. We want to set the stage with the understanding of what's happening for the patient. Here we see some distraction, some vital signs that are concerning, and perhaps an absence of some of the resources we need. We can move forward from setting the stage after the pre-briefing to roles. This begins to, we think about the role of the team, an understanding that we need a team leader, that we need someone who's managing an airway, someone who'll be getting medication, someone who'll be gathering information, somebody who might be interacting with family members, or if we're talking about an EMS simulation, there may only be 2 or 3 or 4 people. So these roles might be worn by one person may have multiple roles during the simulation. We move our way forward and think about the limitations of simulation. These expensive mannequins still don't approximate human physiology perfectly. And sometimes the best designed simulators, when they are put through the paces, will not behave as planned. So as you plan your simulations, also be willing to be flexible and flow with it when there are errors in the simulation. And we can go forward to the next slide and think about the simulation fiction contract, the idea that we know that we're going to suspend our disbelief and we are going to treat this like it's really happening, so that if we are confronted with somebody with a horrible injury, we've gained some experience in managing it and are better prepared. And we can move forward. The idea for education versus assessment is that so much of what we're doing is what we call formative simulation. This is a way to learn. It's not being used as a test. It's not high stakes. It's not going before the national reg or before getting your PALS certification. There is a place for summative simulation, but the type we're talking about here is for education. And that the outcomes of the simulation aren't going to be used in a punitive way, and that there's no stakes as far as promotion or the like. And we can move forward. And that also what happens in the simulation stays in the simulation, so that that people feel safe and they can perform well and learn well. We can move forward. We've talked about pre-briefing, we've talked about simulation, a bit more about debriefing, which is a way to reflect after the experience and improve future performance. We've talked about this in a fair amount of detail. I'm going to move through the debriefing slide somewhat quickly so that we can get to some of the resources that we promised that we'd share with you. But let's move on to the next slide. We've talked about how debriefing is different from feedback. To underscore it again, we are respecting, we can click to the debriefing portion for comparison one more time about the flow of information between 2 adults who have experience and want to do better, between the facilitator and the learner. Moving forward to the next slide. We've talked about a number of the debriefing skills already, including the PEARLS model. I'm going to highlight a couple of my favorites, including the 3D model, because it's easy to remember. There's initially a diffusing phase. People are getting over the emotions of having just gone through a pretty realistic simulation, then discovering. Tell me about your thought process as you approach that patient. I noticed that you did this action. Tell me about your thoughts regarding it and how things went. And then finally, deepening. How does this apply to future patients? One of our goals for this was to help you understand to thinking about foreign bodies in children who have stridor. Please tell me a few take-homes that you might have from this simulation and how it may affect your practice. We've talked about PEARLS. That's the one that's going that's in more detail with a QR code earlier. And there are a few other great resources. The best debriefing technique is the one that you put to use and that you feel comfortable using and feels like a good fit for the way that you like to teach and the way your learners learn. There's no magic to any one of these, but have 1 or 2 of them in your back pocket and some of these techniques, because they'll help you improve the educational experience for your learners. Next slide, please. Another way to think about it again is reactions or diffusing, descriptions, which is similar to the discovery phase and also includes analysis, and then the summary or deepening phase. How are we going to put this to play? First, what was important for the learner? What are the scaffolds, et cetera? The reactions phase is 3 to 5 minutes, and it allows people to blow off steam and get insight for what was important for them, because it's a bidirectional flow of information. After the reactions phase, we move on to the next slide and think about neutral question use, but then we think about description and having a scaffolding for our learning. And it's brief and thinking about a shared understanding of what happened in the case, asking one of the participants to give a brief summary of what happened for the patients. Next, we can think about some example questions like what were the major medical and teamwork issues you had to deal with, and then going deeper on those. And then the analysis phase is to reshape the frames, understand where the learner was coming from, see where the gaps might be, and how we can a preview of what was covered and overarching learning objectives. In discussing each learning objection with an action inquiry method. For example, I noticed that you patted the child's shoulders, and tell me more about that and why you did that and what other ways you might manage a child's airway differently. And we can move forward from the analysis phase and think about debriefing with good judgment. Again, advocacy or action inquiry is stating what you saw, state what your judgment is, and then asking about their frame. Tell me about your thought process in doing that action. Moving forward from debriefing with good judgment, we can move to our next slide. We can say, I saw this. I think that there's an opportunity for improvement here. And then I wonder what your thoughts are about ways to improve this management. And that piece is really crucial because it opens the door for that bidirectional flow of information and respects the learner. Some additional advocacy statements. Essentially the column on the left isn't so good, and the column on the right is a way to foster discussion and may work better. Listen, these are our protocols. This is what we got to do. If you go pulling something like that, it's not going to work out very well for you or for your patient. It's what we do. So we always do. Versus, I've been in this situation before too. And when I do this, this is what works for me. It seems to me that if we approach it this way, there's an opportunity to achieve all those goals. From my perspective, I can understand what you're saying. I'm concerned about the potential consequences that we should explore regarding that medication for this sort of patient. Here's another way to go about doing it, and so forth. So stating your own view, but also doing it in a way that encourages learning rather than blocking learning. Next slide, please. We've talked about action inquiry, and I think we can move on to the next slide. Some good examples here, though, regarding chest compressions and noticing that there was a delay in chest compressions. How do you see the situation? What do you think? And there may be the opportunity for a learner to say, yeah, you're right. I got distracted by what was going on and we stopped chest compressions. I recognize that we need to have continuous chest compressions as much as possible. We can move forward. The summary phase is just that. It's where we close the debriefing and we summarize important learning points. These are perhaps the things that people will take from the simulation, remember days and weeks and longer later. In having each person state 2 takeaway points and key learning points, having them provide the information seems like a way to make things stick better rather than me, the facilitator, saying a few more things. And it also is a good way to check in one more time with what the priorities have been, what the takeaways have been for the learners. Next slide, please. Okay, we've talked about debriefing, feedback, and pre-briefing. We're going to talk a bit about repetitive practice, then we'll move on to clinical variation, valid simulators, and the like. Years ago, for those of us who have been doing this for a while, the see one, do one, teach one model reigned, but it is not what we want to do, because I know that for every procedure or technique that I've seen one time, I'm probably not competent or ready to do the next one, and certainly not competent after doing one, right or wrong, to teach one. So what can we do to move beyond this? Let's move forward. We want to see some, do a lot of simulations, prove with deliberate practice that we can do it perfectly, Vince Lombardi, then do one. From an ethical standpoint, that seems like the right thing to do for anyone's child and what I'd want for my own children. And then we do more simulation. We're talking about pediatric EMS. Critical care of children doesn't come up that often. We need to keep ourselves sharp and ready. And we want to do more simulations. So as we move forward in the presentation, here we see time on the x-axis, skills on the y-axis, and we see a steep learning curve from up to getting to the point. The green line represents being competent and feeling ready. And I never feel more ready to care for an ill or injured child than after I've spent some time in the sim lab or I've just resuscitated a kid. But as time goes by and months go by since maybe I intubated someone or since I did a spinal tap, my readiness falls below the green line. A trauma comes along and maybe I improve my readiness and I get jolted to the point of near competence. But I need over time to keep myself sharp, and simulation helps work against this skill decay. We move on to the next slide, and we can see that simulation and having refreshers is a way to keep ourselves above the green line more often. And if we do a lot of simulations and a lot of refreshers and keep ourselves sharp, we can consistently stay above the green line. Or if we're in a place with a whole lot of volume of critically ill and injured children, which doesn't apply to too many places. Now we really can move on to the next slide. So using psychomotor skills and doing training can be a way to combine our mental and motor activities to have a manual task. And you can see some of the tasks that might be done by EMS, including placing an IO or placing a jet ventilation or an alternate ventilation site when there's a do not intubate, cannot ventilate situation. These are ways to practice deliberately and improve our competency. And we can move forward, but just within mind, the idea that simulation is a way to do this. So before we even do the simulation, we do the cognitive phase. We learn, we watch videos, we read, and we perhaps see an expert who does a demonstration on the simulator to get ourselves ready, to give ourselves the cognitive understanding of the task. Then, moving forward, we practice and practice some more and move toward mastery learning and deliberate practice. These are the ideas that at the end of that simulation, a learner is able to perform the practice perfectly. And then, doing some additional training as far as just-in-time training for somebody who's done practice of, say, a spinal tap or bag valve mask ventilation, then doing a summative simulation, and then doing it and maintaining the skill using more simulation. We can move forward. We've talked quite a bit about mastery, learning, and deliberate practice. And the only thing that I'll highlight for you here is that it's purposeful and repetitive. And depending on the skill, is going to vary as far as how often someone needs to repeat it, or how often they need to practice it. It could take hours before my skill decays, or could be that it's durable and lasts for months or longer. We can move forward, please. Clinical variation with a range of difficulty. Once we've reached mastery, we can move to the next slide and think about mixing things up. We've said this piece already. Only 10% of EMS calls, give or take, are pediatric, and less than 10% of those pediatric calls require any kind of intervention. So that critically ill or injured kid, we need to stay sharp because it doesn't happen often, but the stakes are high when it does happen. We can move forward, please. So what to simulate? We simulate the psychomotor tasks. We simulate the decision-making in real time, and also that feedback loop of I did a task, I gave a piece of equipment to the patient, I placed an airway, I did vascular access, and now I'm going to reassess what's happening for the patient. Have they progressed from respiratory distress to respiratory failure? Is their pain better? Are we doing appropriate CPR based on the age of the child? And then also simulating teamwork and communication. Teamwork among the EMS crew, teamwork with a medical director if necessary, communication with the family, and also bringing in aspects of patient-centered care. Next slide, please. We know that simulation has been shown to improve airway management and all that you see there, improve chest tube assembly, improve management of circulation, and time for primary and secondary surveys of patients, and also improve family-centered care. And it's one of the things that you all as pediatric champions are advocating for as far as improvement in care and better communication. So moving forward from what we do, this platform is the Kearns method for developing healthcare curricula. It takes us from seeing what the problems are and what we need for, say, EMS learners specifically to know, to setting up goals and objectives, just like we did at the beginning of this talk, through education strategies, the use of simulation, then implementing the learning, and then evaluating how things went. And then the cycle feeds back on it. But we are here to say that the goals and objectives, next piece of the it depends on the goals and objectives. Whatever it is we're trying to achieve, that's going to drive all the choices that we make down the line. And then it's going to be what ultimately helps us to solve the problems and meet the needs of the learners. Next slide, please. Valid simulators. Let's take a look at some simulators. Let's move on to the next slide. In a world where there are costly simulators that cost tens of thousands of dollars, I'm here to say the potatoes that the farmers dug up last month can serve as a simulator. If we all agree that we have a contract in simulation that this is the patient and we are going to try to resuscitate this potato, then by all means, it can help us practice our communication, our diagnosis, our assessment, and maybe even our skills. Vascular access on the potato. It doesn't need to mimic human physiology, but it represents the patient. It can be used for teaching tasks like injection, vascular access, lumbar puncture, and the like. Moving forward from a very low fidelity simulator, we can move on to some other low fidelity simulators on the next slide. If you don't have a simulation lab, you can have a low fidelity simulator that is a child's toy, especially with some of the resources like SimBox that I promise we will talk about. There could be some obstacles to buy-in as far as the realism of this simulator, but the same is true even for the most expensive simulators because they're not people. And we can augment them with audio and visual aids. If I have a YouTube video on my phone that's ready to make the sound of a baby crying, and if I have an actor or maybe an EMT student who's willing to portray the child's parent, that can make everyone have a lot more buy-in as far as the portrayal of patients. And it's also a good way to portray multiple patients and overcome some of the costs there. Moving forward, if we think about how we can use moulage to make a low fidelity mannequin look more realistic, like this one, and moving forward some more, we can think about how we can move from low fidelity simulators to the next slide to medium fidelity ones. So resuscitation kids and ALS simulators have some portrayal of physiology. They have breath sounds, but no chest rise. These are moderately expensive. We can practice airway skills with them. And just like with the low fidelity simulators, we can augment them with audio and visual aids. And they can help us achieve some of our psychomotor skills. Moving forward from here, some other examples include high fidelity simulators. For the cost of this high fidelity neonatal resuscitation mannequin, a person could buy hundreds of low fidelity dolls. And depending on how our goals and objectives are being met, we may not need a high fidelity simulator. Moving forward, this is the closest we get to human physiology. There's a wide range of sounds that can come from the mannequin. It can be pre-programmed to respond to certain interventions, but they're fragile, they don't travel well, and they're expensive. Moving forward, the highest fidelity we can get is a person. However, a person, we can't ethically be placing interosseous needles or invasive airways for this person, but we can get real buy-in and realism, and this person can be harmed. And depending on if it's a standardized patient or if it's a volunteer, like one of the Cicero kids, there may be some expense associated with it or not. Also, actors tend to tire and they may not act in the same way later in a simulation day the way they did before. Let's move forward, please. We can also combine high fidelity mannequins and people. Here we see an actor who's portraying a mother in labor and in the birth of a baby. So this can be a really useful simulation for EMS, particularly for planned and unplanned home births. We can move forward. If we're talking about disaster training, if we're talking about conjoined twins or obstetrical training, there's a need to simulate multiple patients. I'm going to encourage anyone to answer Brian Zimmerman's question in the chat regarding grant opportunities for high fidelity sim mannequins. So for multiple patient sims, we can portray multiple patients. Let's take a look at that. If we're doing a live simulation, there's some advantages in that there's realism and it's a chance to debrief, as we went into in some great detail. There can be gaps exposed in the system, but for EMS, it can be costly and there can be scheduling constraints. We can only get through as many learners as come to the Tuesday night training session or are available during a shift. Moving forward from live simulations, we can take a look at other sorts of simulations, including multiple patient simulations that have more than one type of patients. And we can think about all of the different participants that might be included, whether it's a multidisciplinary sim or we focus just on EMS. Moving forward from this sort of multi-patient simulation, the next several slides, which we'll click through quickly, include a mix of medium fidelity simulators that portrayed mass casualty incident. And now we see 3 of the Cicero kids and 2 of their friends who depict some injuries. One thing that I found is helpful for getting buy-in from kids is letting them pick their injury and letting them touch the moulage to get good feedback or buy-in. And also if that kid shows any signs of distress, pull them from the simulation and be ready to support them. Also, is this ethical? Maybe not, but bribery works well. If they know that there's something good coming after the simulation, it helps with buy-in. Let's move forward and take a look at a couple other slides, and then we're going to move forward to talking about a couple low-cost simulators or no-cost simulators. So we know when it comes to multiple encounter simulation or multi-patient environments that the use of increasing scenario complexity can be achieved with mass or multiple patient simulations. We can look at it using the simulators to the highest extent. A lot of times high fidelity mannequins get used like low fidelity mannequins, and it may not be necessary to have those. We can have high workload environments like a busy EMS site or a busy emergency department, and then expand our need for communication about patients and also really rich debriefing. Moving forward. You can take a look at some work that some somewhat reliable authors wrote regarding mass casualty simulations. But basically, the upshot of this work that we did was that mass casualty simulation improved EMS triage, not just initially, but 6 months later. So another example of mass casualty simulation from our neck of the woods. Please move forward if you would. Okay, and then finally, defined outcomes is an element of effective simulation. Moving forward, we've been talking a whole lot about formative and educational simulations. That's what we're encouraging PECs to do in their agencies. Summative simulations are the sorts of things we might do for licensure, competency, getting one of the American Heart Association courses or the like. Moving forward, we think about assessment tools that we might use as part of feedback for a simulation, whether it's formative or summative. And the tool really needs to be valid. In other words, does the tool measure what it says that it's going to do? We're not asking for PECs to develop valid tools, but we'd encourage you to be discerning consumers and use tools that have been shown to be valid so that you know that the outcome of the tool is useful for you and for your learners in your agency. Okay. And here's an example from a study by Lammers that takes a look at airway management and the management of a critically ill child. That's all we'll say about that as we move forward. This is an important slide when we think about going from being unconsciously incompetent as a novice to moving forward to being competent and ultimately an expert. If I am unconsciously incompetent, I don't even know what I don't know. And hopefully, everybody working in healthcare has moved beyond that. Conscious incompetence is where a lot of folks in EMS and also who work in general emergency medicine may feel about caring for children. I know that kids are different. I know that there are things I don't know, and I need to work on that. Conscious competence is saying, okay, I know that if I use my Broslow tape or an app or the hand-heavy system or whatever system works well for me, plus the resources in front of me and what I've learned, that I can manage a child's airway. And unconscious competence is the ability to deal with new situations and adapt what we've learned as we work from proficiency to expertise, to ultimately being unconsciously competent, not needing to stop and think, but just knowing what to do. Let's move forward. And this is a global assessment of procedural skill. You might ask a learner to say, where am I when it comes to managing pediatric airways? Knowing that we have only 10 minutes left, I really want to get to the good stuff. Dwayne, please, blatantly flip through these until we get to, yes, this is great. We want to implement pediatric EMS simulation at your agency. Let's move forward. We're going to avoid this one. I want to get to some of these resources and then give a little bit of time. So here's a readiness toolkit with a QR code that can help you. This is from the EIIC, and it's a national resource that has everything from 15 resources for EMS procedural skills, some behavioral and communication skills in this time when so many children are having behavioral health issues, cognitive skills regarding pediatric issues, and even a training grant opportunity, which may or may not address some of the needs that were addressed or that were mentioned in the chat. So this is a toolkit that has a number of different pediatric training resources, including simulations and psychomotor skills. Next slide, please. Okay, so when we think about free open access medical education, or FOAM, this is freely available, does not require a budget, and can be used anywhere. Let's move forward. Okay, and when we think about other books that are available and that are freely available, at this QR code includes a resident curriculum for simulation, pediatric scenario guidebook, and simulation cases. And these resources are available, if I'm not mistaken, at no cost and are available off the shelf, including a source that is not too far away from us at NYU. We can move forward.
The pediatric scenario guidebook is adapted for Pennsylvania, is available on the PAEMSC website to download and access, and it's a very good resource.
Yeah, and,
Thank you.
and the big push I would make with this slide is don't go out and invent your own cases, adapt these to fit your needs.
Absolutely.
Yeah, spending a lot of time trying to prep. I would say, Marc, for this slide for virtual resuscitation room, if you would like to conduct simulations with individuals from home, please drop us a note. Look at this site. It's very user-friendly. It's called the Virtual Resuscitation Room. And I believe there's a QR code coming up. It's very intuitive, but I would argue that the SimBox with in-person simulation is superior. I've been involved.
Absolutely. We've definitely saved the best for last. Let's move on to the next slide and delve into, here's some more about SimBox. So SimBox adapts things from the idea of a meal in a box concept. There's a number of companies that'll send you a recipe and all the ingredients you need to make it. Likewise, SimBox gives you the scenario, gives you a video that's freely available on YouTube that depicts the patient's vital signs, and in most cases also has a picture with the patient that shows a patient who's having respiratory distress, a patient who's having a seizure, a patient who's crying because they have burns over a large total body surface area. And all that you need, in addition to the resources that SymBox provides at this QR code, is some depiction of a patient. It could be a doll, it could be a low fidelity mannequin, and also an internet connection, and a facilitator, whether that's you as the pediatric champion or one of your colleagues who's willing to work with the learners. That's it. And I think that this bridges the gap between high fidelity simulation and all of its costs and low fidelity simulation with problems with buy-in in a really nice way. We're using it with our targeted issues grant here about pediatric emergency care coordinators. And it's been met with really good reviews from our learners and from our PECCs. Moving forward, there's some additional information about SymBox. And it has all the elements that we've spent the last hour and a half or so talking about regarding pre-briefing, pre-briefing as far as setting the stage, doing the simulation, and then doing the debriefing. It also has prompts and information for perhaps you're a PECC, but you haven't done a whole lot of simulation yet. It has a guidebook that helps with facilitating. I'm going to really be nerdy here and mention Dungeons and Dragons. I think you can draw some analogies between SymBox in training in EMS and the Dungeon Master's Guide and the modules that people might use in Dungeons and Dragons to have a game around a table. This is a way to give the resources to a willing facilitator who is working on their own feelings of self-efficacy and readiness to do education. And we also are available if you're getting ready to do a SymBox, if you have questions, and we'd be happy to answer them. So it's a great resource and has a growing number of cases. Let's take a look at just a little bit more about that and then we'll wrap up. Here are all the cases that are currently available as of October. There are 11 pre-hospital cases that are ready to go. And we encourage you to take a look at SymBox, which again is freely available and ready for you as learners. So I think we'll wrap up.
Marc, if you just want to, if you just want to go to the next slide, just real quick. So keep going, Dwayne. Next slide. So the SymBox can be conducted with everyone in one room like this. Next slide. I think the construct that we wanted to get to is if the learners are in one room, that facilitator can also be in the room. Next slide. But another option is remote facilitation. So we've done a lot of this now in Alaska, as well as with rural and critical access hospitals. So I would be home as the facilitator, Marc Cicero would be home, but you and your team can get together in the ambulance and or in your training room. And the benefit of this is it saves a lot of travel time, can also be flexible if you need to cancel and things of that nature. So I just wanted to bring up this concept of what I would call remote facilitation as opposed to an all virtual simulation. Next slide. We do have the plan to integrate pediatric readiness into some of these discussions. Next slide. Just wanted to keep going. Sorry. Keep going. I'm sorry. Keep going. We can come back to some of this after. This is what I would see as your remote facilitator. Keep going. And there's two options here, and we could share these slides for either in-person or remote facilitation. Keep going. And what I'm going to do is just bring up this slide. Keep going. I'm not sure if we have the image of the actual SymBox site, but if we don't, I just wanted to share that there's two key elements. Keep going, Dwayne. And if you click on, that came across weird here, but if you look at this QR code, it'll take you to our casebook. And there's really two elements. One is a PDF document, that's that script that Marc mentioned, and the other is the video. So if you don't have an internet connection, you certainly could, which I know is a problem in many ambulances, you could download that video even onto an iPhone or an iPad and have that scenario user guide with you. And really one of the key benefits that we think is in the scenario user guide is you don't need to be an expert, you just need to be a champion. So within that user guide, we have lots of infographics and teaching materials. I'm wondering if they're on the next slide, or if we didn't get them in here, keep going. So we have the YouTube video, keep going. And you can keep going, go past that, actually, Glenn. So you would adjust the YouTube video as necessary. Keep going, next slide. I'll tell you when to stop. I guess we did not put it in there, but within the end of each scenario guide, we have about 5 pages of really pragmatic resources to teach about that case. So sort of if-then statements. So if didn't adjust airway, here are some manipulations of the airway. If began CPR in a neonate that should not have gotten CPR and back valve mask, reviewing some algorithms. So really putting everything in a one-stop shop.
Thanks for that, Marc. And I think that, just listening to Marc Auerbach talk about Symbox, I think that the degree of enthusiasm that we have for this really comes through. Because in the past, and really at present, it can be difficult for simulation programs to get off the ground at EMS agencies because of issues of resources, cost, or even just the barrier to how do I do a simulation? That doesn't really feel comfortable, or I haven't been trained. This can help bridge those gaps, and we really think that that it's a worthwhile and growing way to improve pediatric readiness for EMS, and also for community hospitals and children's emergency departments as well. So we've reached the top of the hour. Thank you very much for the opportunity to speak with you all. Thank you for your roles as PECs in your agencies. We're happy to stay online if there are questions, or if there's feedback or anything that needs to be clarified regarding what we've presented here today. Thank you.
So thank you to both Marcs for your time and a tremendous amount of information. I will echo Dr. Cicero's opinion that there's a lot of enthusiasm here, and I will try and put together a little bit of a kind of a one-pager of Symbox specific information and resources that I can share with the PECs either after this session or for the next session. Just a reminder, our next session is scheduled for January 18th at 2 p.m. However, we are also working on a pediatric specific education day, partial day that may fall on that day, and this session may be part of that. More to come with that in the future here. If you would like to get continuing education credits for this session, there's the link or the QR code to get to it. It will be active until noon on Friday. This coming Friday, in order to receive that credit. A reminder, in the calendar invite, the YouTube link for this video will be up at 7 o'clock tomorrow night. So if you want to go back and review what was here, certainly can do that. And also, I will have the slide set available in a PDF document to ship out, so it's a little more manageable and size-wise. If someone would like to have that, just shoot me an email, and once I receive a group of the emails, I'll send it out to the group for a little bit more time efficiency. Any quick questions here? We're a few minutes over, but I appreciate everyone's time. Any questions for the doctors or myself? Okay, I'm going to leave the QR code up for a while. If you need it, I'm going to stop recording. And thank you again for your time today, and everyone have a safe rest of the week.